Hey everyone, we're going to go ahead and get started. Thanks for tuning in for the Cold Case Conference today. Super excited. We have 3 discussants today, 2 of which are new to this format. So we've got one of our new excellent interns, Jordan Williams, and then 2 third-year residents, Shoaib, Fakhri, and Sam King, who are going to be helping out. This is a case that I had about 1.5 years ago when I was a resident at UCH, and I prepared it today. For the future, if you guys have any questions or if you'd like to participate or discuss, please just shoot Corey and I an email. We are always looking for discussants and participants. So the only other thing we'll say is if you are not muted, go ahead and just try to mute yourself while you're talking if you're not one of the discussants. All right, so let's go ahead and get started. So for our discussants, you guys are working as the UCH MICU night resident or night intern, and a patient is being transferred to you from a freestanding ER for further management. So their chief complaint is productive cough and dyspnea on exertion. HPI, this is a 36-year-old male veteran with a history of bipolar disorder and hypertension, presenting with 3 weeks of worsening malaise, productive cough, and dyspnea on exertion. He states that he initially developed flu-like symptoms approximately 3 weeks ago. At that time, he also had an intermittently productive cough, productive of white and yellow sputum. Since the onset of his symptoms, his cough has worsened to the point that he's producing sputum throughout the day. The sputum has remained white to yellow. He reports some very small flecks of blood in the sputum for the past week. In addition, since his symptoms started, he's been less active, has had more difficulty riding his bike, and says he's gained 10 to 15 pounds of weight. He says he has daily fevers, chills, and night sweats during the same time frame. His review of systems is otherwise completely negative. So with that first piece of information, I'm going to turn it over to our discussants to let us know what you're thinking.
Jordan, do you want to take a shot at this first?
Sure, I'm happy to start. And I'm happy to say a lot of I don't know that today. But whenever I approach a case, I always think about 3 things: the who, what, and when, to figure out like who the person is and what they're coming in and with their history, what the clinical syndrome is, and then the duration or tempo of disease. So in this case, we have a somewhat younger male individual, so 36 years old. Maybe they haven't had enough time to accumulate a ton of chronic diseases, although they have this history of bipolar disorder. Who knows what medications they're on, maybe lithium, I don't know. And then they're coming in predominantly with a pulmonary syndrome with fever and cough, which seems to be subacute in nature. Just kind of reviewing a whole bunch of the other positive review of systems. They have fever, indicating that they have some sort of inflammation, in which case we activate our I-made mnemonic: inflammation, malignancy, autoimmune drugs, and endocrine causes. It seems like base rates of diseases, obviously, infection is going to rise to the top, particularly in a younger individual who may not have a lot of previous comorbidities. And again, thinking about pulmonary infections predominantly. Second, we have some alarm symptoms of this significant weight loss and night sweats. Of course, this makes you think about more about malignancies perhaps, or some certain types of infections like tuberculosis. But that's going to be kind of in the back of my mind as well as we're approaching this case. Dyspnea, again, you can think about your dyspnea pyramid with pulmonary causes, cardiac causes, anemia, and metabolic issues. Again, it seems like we're localizing more to a pulmonary problem in this case. The fact that he's producing all this sputum, I'm not entirely sure what to make of it yet. I don't know if this person has a history of any COPD whatsoever. The fact that there's a small amount of hemoptysis, I am not making a ton of at this moment, but if he started having more predominant hemoptysis, that would kind of trigger another set of thinking. Of course, again, if you're thinking about tuberculosis and malignancies, that might also make the hemoptysis more prominent in my thinking. But right now, I'm still thinking infection of some sort until proven otherwise, some sort of pneumonia, but I'll keep my differential broad as I can.
Yeah, that was great, man. I feel like interns are just getting smarter and smarter. It's insane. So yeah, I think that's definitely how I would approach it as well. The other thing that I like to do is I like to put things into illness scripts and then try to find something that doesn't fit an illness script. So this gentleman's coming in. He has a cough. He has sputum production. He has a little bit of hemoptysis and fevers and chills and night sweats. You know, a lot of this points towards exactly what you mentioned, that could this be an infection of some sort, right? The one thing that doesn't fit a lot of the illness scripts that I'm thinking of is that weight gain. When you start thinking about things like an infection.
Oh, gain weight.
Yeah, exactly.
Not weight
When
loss.
you start thinking about like things like an infection, usually a lot of people have malaise and don't eat as much and they actually end up losing weight. So it's a little bit peculiar that someone has weight gain. One thing that does make you think about it a little bit is, could this be a new diagnosis of something like heart failure, right? With dyspnea of exertion, weight gain, you can definitely have a productive cough that looks a little like hemoptysis with heart failure. So that's one thing to think about as well. And then also, I think we'll get a lot more information as we get medical history, exposures, but always thinking about what other things can cause a subacute presentation, as you mentioned. I don't know if you had, Sam, if you had any other thoughts.
No, that's exactly what I was thinking. I agree. The weight gain was the weirdest part for me. That doesn't fit the typical sort of what sounds mostly infectious, but could be lots of things like you guys mentioned.
Yeah, that was absolutely phenomenal. I honestly have absolutely nothing to add to that. I think, Jordan, that was one of the best kind of summaries we've had so far since we've started this series. And I think one of the things that Jordan did, which was excellent, is he really was very deliberate in his thinking. So he took the patient, he specified what their comorbidities were, their age, he gave the tempo of the illness. So is it chronic, is it subacute, or is it acute? And then he really talked through that entire broad thought process. And I think that's the thing that we're always trying to do, is start broad and narrow as we get more information. So that was absolutely phenomenal. And then Shoaib and Sam, I completely agree. I think, especially as we become second and third year residents, we have these specific illness scripts in our head, and what matches, what doesn't match. And I'm completely with you there. When I first admitted this patient, that weight gain was sort of one of those weird outliers. All right, but I think you guys are all on the right track here. And so you guys are also interested in more information. So let's go ahead and do that. So for the second part, his past medical history, he has a history of bipolar disorder, diagnosed about 10 years ago. He has never been on medication for his bipolar disorder. He has hypertension and is not on medication. He has no other known medical history. His social history: he's a former tobacco smoker. He quit about 9 months prior to the current presentation. He previously smoked 1.5 packs per day for 20 years, giving him a 30-pack year smoking history. He does not drink alcohol and never has. He has never used any other drugs. He has never used marijuana. He is currently living alone in a hotel room and has been for some time. In terms of his exposure history, he's a Marine Corps veteran who served 2 tours in Afghanistan between 2011 and 2013. He does say that he had significant burn pit exposure while stationed abroad, but denies any other exposures, any blast injuries, or any similar problems. He has not been around any pets or animals, and he has no other known environmental exposures when you ask him a long list of questions. His family history is unknown, and he is not taking any medications currently. He's not allergic to anything. All right, take it away, guys.
Yeah, I can start it. Not to put all the pressure on you, Jordan. So yeah, a lot of interesting things here. I think some stuff that we're very interested in was his tobacco history, and he has quite a significant tobacco history, which makes you concerned that, maybe does he have an undiagnosed COPD? Remember, you have to have pulmonary function tests to diagnose COPD, but you can get emphysema from just looking at a chest X-ray and CT scan. So that's something to think about. His exposures are also interesting. As someone from Afghanistan, I wasn't born there, but I know a lot about Afghanistan. And there is significant burn pit exposure. There's also a lot of different things in terms of, the exhausts and the sand exposure and also different microbes in Afghanistan. So I would do a little bit more digging in terms of what other exposures are potentially from Afghanistan. But it sounds like this was a while ago, and he hasn't had that exposure more recently. So again, a little bit lower than my thought process. No pets, no other environmental exposures. So this is all helpful in the setting of thinking of other what I would call like other lung diseases that are induced by exposures. It doesn't really give us too much more information in terms of helping with his current presentation. Again, the weight gain is a little bit odd. Someone with COPD coming with an exacerbation, you still don't expect them to have that weight gain. One thing that you can have is, could this be a new diagnosis of something like metastatic lung cancer? I mean, it does fit with the night sweats, chills, but again, weight gain is not something that I would think of. So I still think we need to do a little bit more digging. In terms of my differential, I think keeping pneumonia up there is good. CHF, also a new diagnosis of that, is also good. I would also think about things like interstitial lung disease of some sort, given that exposure history. And then also any type of malignancy, particularly lung cancer. So those are the thought processes that I have. And then, of course, a COPD exacerbation, but again.
Awesome. I don't have too much to add to. I'll go to Sam. Do you want to go ahead?
Oh, I was just going to ask to clarify, Danny, what was the time frame on when he was in Afghanistan and like any recent travel, or was that remote?
Yeah, great question. So he was in Afghanistan about 8 years ago. Since he's returned to Colorado, he actually hasn't left the greater Denver area, and denies even basically going past the Front Range.
Okay, thanks.
Yeah, I too think it was echoing the first things that were said, like the exposures being interesting for always a pulmonary history. But going back to the weight gain, I just wanted to think in reverse. Often we think about weight loss in terms of, are people consuming enough calories, absorbing them, or is there an issue with their metabolism being ramped up? So conversely, how could we think about weight gain? I think we're familiar with heart failure and states of hypoalbuminemia being issues for retaining water. Conversely, issues with endocrine things like having a high cortisol state or a low thyroid state. So I'm just keeping those also in the back of my mind. I know he has had bipolar disorder, doesn't say he's on medications, but I know there's a lot of psych meds that are associated with endocrinopathies or issues with weight gain, a lot of the antipsychotics. So those are other things that I'm just floating in the back of my mind as we continue forward.
And George, you said something that actually made me think of one of the things that could potentially be going on to think about is, as you mentioned, as like a hypoalbuminemic state and weight gain. Could this be some sort of like a pulmonary, right, with a little bit of the hemoptysis? So that's something to also think about. And again, with a lot of work, we'll find out some more as he's just excreting a lot of protein in his urine. It's just something to think about.
Again, you guys are crushing it. That was wonderful. And I think just to summarize what you are saying, because you're throwing out really good illness scripts and schemas, is you guys are really localizing this illness to the chest. So whether it's the heart or whether it's the lungs. And it also sounds like not only are you localizing it to the chest, but you're localizing an inflammatory syndrome to the chest. So something which is revving this guy's metabolism up, or something which is causing him to also be febrile, and sort of pushing us forward in that direction. Is that a kind of a correct broad summary of what you are thinking?
Yeah, totally agree.
Cool. Any other social history questions or clarifying questions from those first two pieces of information before we get into the meat of this case and start getting some objective data?
This is only pulmonary history we know of, right? Nothing like this has ever happened in before. It isn't like recurrent. It's just 3 weeks.
Yeah, great question, Sam. Yeah, this is his only pulmonary history. He says that even when he was deployed to Afghanistan, he never had any issues with dyspnea on exertion, exercise tolerance, or anything like that. So as far as he knows, this is the only time this has ever happened. And I think actually one other good thing to talk about real quick, just because we're so early in the year, and I know Sam and Shoaib are more familiar with this, and I think Jordan is too, but when you guys are asking your history for pulmonary exposures, what do you guys usually ask? Like, what buckets do you break that down into?
I think of like water and mold. That's sort of one category of like any standing water nearby, like swamp coolers, recent flooding, risk factors for having mold in the home.
Sam,
Yeah.
what illnesses do you associate with the water and the mold?
Like hypersensitivity pneumonitis or that's really the biggest one.
Yep. No, that's great. And then what other buckets do you guys usually think of when you think pulm exposures?
So I think I like to take a step back too and think about things like, is it environmental? As in, like, there's a couple of things that I think of. Is it environmental? Is it from the sky or is it from the ground? Other things are, is it work related? And then other things is it household related? Is it pets, water, mold, all that good stuff. So those are the big buckets that I put in. So in terms of environmental, like, you could have like, silicosis or beryllium exposures. That can also fall under work. And otherwise, it's in terms of where you're living too. So you can actually get like hypersensitivity pneumonitis from different fungal infections as well. So if you're like a spelunker, or if you live in the Ohio Valley, so thinking about things like that. In terms of household, yeah, pets, water, mold. I've actually seen someone with basically a hypersensitivity pneumonitis because he was feeding a bunch of seagulls. And so always ask, even if they don't have pets, hey, do you go out into the marina and feed a bunch of seagulls?
And then obviously smoking.
Yeah, I think that's the big one is we ask everyone about this, but make sure that you're always clarifying that smoking history. Because that is obviously the most low-hanging fruit of our lung exposures. But yeah, great. So you guys hit it. So environmental, work, household, essentially having them walk you through their day or their last decade of their life and just seeing if anything pops out. Great. All right, let's give you guys some more information. So, yeah, let me just stop sharing here. All right, so third part of information, this will be his vitals and his physical exam. So on his vitals, he is afebrile with a temperature of 37.3. His blood pressure is 150 over 101. His heart rate is 105 beats per minute. His respiratory rate is 32 breaths per minute. And he's satting 76% on room air. He's requiring 6 liters nasal cannula to keep his oxygen saturation greater than 90 when you see him on arrival to the hospital. On exam, he's generally ill-appearing, but does not look like he's in any acute distress. His HEE and T exam is unremarkable. His JVP is not elevated. He's regular rate and rhythm, intermittently tachycardic, and has no murmurs. On his pulmonary exam, he has increased work of breathing, but no accessory muscle use. He has bilateral crackles in all of his anterior and posterior lung regions during inspiration and expiration. And then during exam, he's coughing up whitish yellow sputum. His abdominal exam is unremarkable. His neuro exam is unremarkable. There are no skin changes or any concerning rashes. Everything else that you evaluate is normal. All right.
Sweet. I'm happy to start if you want. Always start with the vitals because vitals are vital. And just looking at them, my antennae of concern are up. I know he said generally ill appearing, and just looking at these numbers, I would be concerned. And in the back of my head, I'm thinking, am I going to need to escalate level of ventilation or intubate this patient at some point? Because as we're diagnosing, also keeping management in mind. And then I'm thinking, okay, he's hypertensive, at least he's not hypotensive, but that's kind of an interesting finding. Is that just because of discomfort or pulmonary renal syndrome? Tachypnic, that makes sense given that he's having respiratory problems. I'm assuming that the tachycardia is secondary to that. And then thinking again about hypoxemia or hypoxia, there's the 5 causes of hypoxia, and I'm guessing that this is going to be related to either a diffusion problem. So far, just intuition, thinking about all of his exposures, these inspiratory and expiratory crackles, which might represent some ILD. The sputum could also be an alveolar filling process of some sort. Not entirely sure what to do with that yet. But I'm generally concerned that this guy is sick. Beyond that, I'm reassured that his cardiac exam was normal, which I think we all had a lower suspicion for it to begin with. the abdominal exam. I'm not sure if, if the liver, if you could have felt some weird things on the liver, if there was an issue, considering that we thought about the albumin and stuff like that. I'm curious if his lower extremities have any edema. It didn't look like there was any comments on that, but yeah, that's kind of where I'm going for now.
Sam, did you want to take a swing at this?
Yeah, sure. So that was awesome. I totally agree. Based on vitals and also respiratory pulmonary exam, concerned about this guy and understand why he's being transferred to us in the NICU. And I agree, especially with diffuse crackles and hypoxia, think about some sort of alveolar filling process. Certainly could be interstitial. Think about that more as bibasilar, but depending on what's going on, could be more diffuse.
Yeah, I think that's awesome. I think, Jordan, you hit it right on the nail. We're concerned about this guy. And I think one of the things that I always like to think about is this something that's acutely caused decompensation? Somebody at 76% on 6 liters breathing that fast, I think there's an acute component to this. Other really important parts of his examination, his pulse pressure is pretty narrow. I mean, he has a high diastolic pressure. So that makes you think about, could this be like a flash pulmonary edema syndrome? The other thing that's important too is for someone that we think of potentially having heart failure, he has no JVD. And so, there's no pronounced JVD for someone coming in this sick, makes me think less so of a potential heart failure and backup of fluid. But again, it was still a possibility. This, I think, all in all, his examination really points to there being, as Danny mentioned, like there's something going on in his chest, right? Whether it's his heart causing flash, or his pressures causing flash pulmonary edema, or something in his lungs, like could he have ILD that was undiagnosed, and does he have an exacerbation? So I think this is all telling us a couple of things. One, we're really worried about this guy. We need to triage him to the appropriate place. And then two, just keep a very close eye on him.
Once again, fantastic job, guys. Perfect. So yeah, I think that's exactly the way I was thinking about these vitals in this exam when I admitted this person. And I think that's excellent. You guys pointed out that while he's afebrile, he's obviously hypoxic, which is concerning. You'll get some more information about that in a second. And then on his exam, even though he's not in acute distress, he's a young guy who's ill appearing. And he's got these crackles throughout his lung, which is the most prominent thing. And I think oftentimes we take for granted how long young people can hold on for before they finally decompensate. But you guys are exactly right to be appropriately quite concerned about this gentleman. Okay, so now I'm going to go ahead and give you guys some of the labs. And I think you guys would probably all order the labs that are about to be given. And so I'm going to give you the labs kind of one at a time, and then you'll let me know what you think. All right. So on his ABG, 7.43, PCO2 26, PO2 of 52. On his CBC, he has a white blood cell count of 46 with 36% PMNs and 7% bands. Hemoglobin is 15.7 and his platelets are 356. I will tell you that a smear and a hematology evaluation had already been completed and shows us that he has leukocytosis with a left-shifted myeloid maturation, including toxic granulation and cytoplasmic vacuolization, most likely reactive in nature and due to a leukemoid reaction. His BMP is completely unremarkable. His LFTs are completely unremarkable. His BNP is 558, which is mildly elevated. His troponin is normal. His CRP is 18, which is moderately elevated. His LDH is 884, which is pretty significantly elevated. And his urine drug screen is completely negative. So I'm going to go ahead and stop there and let you guys discuss these labs.
Yeah, I could talk a little bit about him. So first of all, kudos to the ED getting an ABG on it, room air. That's fantastic. But what that's really telling you right there is he is quite profoundly hypoxic, and the level of his PCO2 tells you he's breathing pretty fast. Just he's breathing off a lot of CO2, which is, for him to be breathing up that fast and his ABG to be normal makes you wonder if there's some sort of a metabolic process going on as well. But the BNP is unremarkable, so I'd be interested in getting a lactate in this guy as well, just for thoughts. Otherwise, I mean, trying to avoid that white count for now. I'll come back to that. BNP and LFT are unremarkable. It's really good to know. But one of the things to think about on those is, does he have elevated creatinine or kidney dysfunction? It doesn't seem like he does. Does he have any evidence of, extra volume causing elevation is LFTs? So hepatic congestion, that's not there. BNP mildly elevated, and so is the troponins. He doesn't have any evidence like demand ischemia. I don't know what to make of the LDH. Usually LDHs and CRPs, I kind of put them all in the bucket and say, okay, these are all inflammatory markers. They can be elevated in certain things. One thing LDH can be helpful for is in situations of hemolysis, which he doesn't seem to be having. That white count, 46, that is quite sky high. First thing I was asking is, should we have a smear to see if this guy has a lot of blasts? Is this some sort of a lymphoma that we're not catching, or leukemia that we're not catching? So that's one thing to think about. Otherwise, there's certain infections that can cause your white cell count to go quite sky high. C. diff is one of the things. He doesn't have any diarrhea. But just, I don't know if Sam, you want to help, or Jordan, but if you guys have any thoughts of what else can cause a white count to be that sky high, besides steroids, C. diff, and cancer.
Shoaib, I agree with lymphocytosis, that profound lymphoid reaction. Definitely think about C. diff. Also, like some uncontrolled nidus for infection, like seen it with sepsis with an abscess that hasn't been discovered yet. And certainly concerning for like primary hematologic process too, that we already have that smear. The thing with the LDH is like LDH, elevated primary pulmonary process. Think about PJP. I don't know why this guy would have that, but I agree. LDH is very nonspecific.
Sam, tell me more about the association between LDH and PJP.
Yeah, I think it's a pretty sensitive finding for pneumocystis pneumonia with elevated LDH, but I don't exactly remember the pathophysiology of it.
This is a good reminder for me that like oftentimes also getting HIV testing and all these things, especially, I don't know, I guess not. I'll take that back. Everyone probably deserves an HIV test at some point in their life, but does this person have another reason to be immunocompromised? And then I agree, the LDH sticking out, I immediately thought malignancy as well. I'm also trying to think back to the initial presentation that this person had, like viral flu-like illness and then acute worsening. Is this again like viral pneumonia followed by superimposed bacterial thing, abscess, as was already mentioned. Again, I think a lot of non-specific findings on these labs, but I also agree that the normal pH with the profoundly low CO2 was weird. So there's got to be some lactate or something hiding around there.
Yeah, so to fill in that gap, his lactate came back at 4. And so there was a very mild lactic acidosis. And then you guys are completely correct. So that differential for a white cell count that high is basically leukemoid reaction, so C. diff, gram-negative sepsis, uncontrolled nidus of infection, versus a primary hematologic process. And then Sam, you're also exactly right. The LDH being elevated in PJP is, it's my understanding it's a manifestation of essentially your body's inflammatory response and cell turnover in the lung to that process. But right, like when you see an LDH that high, primary hematologic process, PJP should be the two things that flash. And then Jordan, couldn't agree more that HIV in almost all cases should probably just be a screening exam that we're getting on every single person who comes into the hospital with an acute infection if they have not previously been tested. So what test, you guys have kind of talked about his hypoxia a lot. What do you guys want to get next? Do you want to get a chest x-ray? Do you want to go straight to a CT, echo? What are your thoughts?
I'd say based on a stability. Yeah. I mean, I think chest x-ray is definitely something we should always get. And you can get that in the room. Sorry, Sam was saying something, so I'm going to stop talking.
No, that's exactly what I was going to say. Chest x-ray is going to happen far faster. And it seems like this guy's O2 stats are okay on 6 liters, but I totally agree. CT obviously requires sending him down multiple floors, usually to a different department. So I would start with the chest x-ray.
I'll be contrarian. I want a CT. I think we're going to get one eventually anyways.
So you will get both eventually, but the chest x-ray happened first. And so I will show you his chest x-ray now. All right, so here's his chest x-ray. And let's see here, Jordan, if you want the first shot at this or if you want to defer to the third years, take it away.
Yeah, I'm happy to do it. I mean, similarly to how you assess an EKG, it's always nice if you have a previous one to compare it to. I'm guessing we don't, but you always, we have the right patient, assess the mode of having the chest x-ray. So this looks like it's an upright. I don't know if I'm assuming this is a portable one, most likely, a portable chest x-ray. So AP rather than PA, so that'll affect your assessment of the heart. Then I kind of use the rib cage mnemonic to assess the x-ray. So looking at the rotation, it doesn't look especially rotated. Inspiration, it looks like there's enough posterior ribs that it's a good quality film in that regard. C, cardiac silhouette. I mean, there's a fair amount of silhouetting, but it looks more, again, like a hill, kind of patchy alveolar filling bilaterally. The heart, I can't really necessarily say that it's enlarged. It looks a little bit enlarged on this film, but I think, with the technique, it's a little bit hard to assess. Airways looks midline. I'm not seeing any splaying of the carina. G, just gastric bubble. E, everything else. Okay, so then the thing that really stands out is this bilateral, diffuse opacities. Immediately I'm thinking ARDS when I see this. I guess it looks like it's kind of more of a patchy rather than reticular pattern. Not seeing especially any nodules. I don't see any effusions and the costophrenic angles, but looks primarily like a bilateral alveolar filling process to me.
Jordan, that's awesome. Thank you for going through all of that. I totally agree with you. I think this, which, as you mentioned, it looks fluffy. When I think of, chest X-rays, and I'm just going to go straight to the meat of this. You think about, is it reticular, or is it which I think of more of interstitial inflammation markings, or is it fluffy, which situation is a little bit of both, but a lot of fluffiness, and that's where I think of an alveolar filling process. And an alveolar filling process, the way you should always think about that is it can be multiple different things, but think about what can fill the alveoli. And the common mnemonic a lot of people use is it blood, is it pus, is it water, is it fat, is it calcium, maybe missing a couple over there. But that's the way I generally think about in terms of an alveolar filling process. One thing that I would caution you is for ARDS, definitely it looks concerning for it, but ARDS is a syndrome, and there's something that always leads to ARDS. So I think we should think about what could potentially be causing this alveolar filling process, and could potentially be causing him to go into this acute respiratory distress syndrome. Sandy, if you had any other thoughts.
No, I agree. I think the only other thing to add is definitely diffuse bilateral patchy. It's a little more basilar prominent and a little less greater than right. And it does look fluffy, but also gets some air bronchograms. So I think there's a little bit more consolidation as well as what might be ground glass versus consolidation in CT.
Again, that was an expert level discussion by everyone. And so you guys brought up two really, really good points that I want to dive in more to. So Shoaib brought up the alveolar filling process differential. So blood, pus, or water, or red, white, and blue. Those are the three big things we think about every single time. But just to make sure we're keeping our differential broad, what else is on that alveolar filling differential that we perhaps don't commonly think about or don't think about as often?
Protein.
Yeah, great. So protein, and what disease entity is that?
I mean, it could be amyloid, for instance. I think. Yeah,
and then also, so amyloid possibly, but more commonly pulmonary alveolar proteinosis, absolutely. And then there's three other things that end up on that differential for alveolar filling.
Lymph.
Cells can do it. You can get a malignant infiltration.
Cells.
Yeah. Great. So cells. So is it like an eosinophilic pneumonia? Is there a hypersensitivity pneumonitis? Are there other types of cells inside the lungs? Absolutely. Two more.
Does he have Vaseline on his nose? So lipids is the other one to think about.
Yeah. So lipids. So Shoaib, what would the Vaseline cause? What's the name for that entity?
Oh God. I don't think I remember, but it's basically the macrophages interact with the lipids, and there you go, lipoid pneumonia.
Yeah, there you go. Yeah, so it's called a lipoid pneumonia. And so the classic test question is a person who rubs Vicks VapoRub underneath their nose and sort of chronically inhales that mineral oil can get a lipoid pneumonia. And then one of the last ones that we actually had last year at this hospital was we had someone who had calcium. And so you can get pulmonary microcalcinosis. And essentially you end up having just calcium deposition in your alveoli. And so while we commonly think about the sort of the big three, right, blood, pus, and water, this differential is a little bit longer. And I think you guys are right on top of it, thinking about all that. And then Shoaib, you also brought up a really interesting point, how ARDS is a syndrome, right? And so just because we're still early in the year, walk me through the 4 different parts of that Berlin criteria.
Yeah, absolutely. So Berlin criteria. So basically, the way I think about ARDS is it's a clinical syndrome and something causes it. The 4 things that I always think about in terms of ARDS, everyone should think about really is 1, hypoxemia or hypoxia, right? And that's based on your P to F ratio. And a lot of people wonder what P to F really means. So what that means is your PaO2 measured on your ABG, so your arterial AO2, and you divide that by your FiO2, which is your inspired oxygen content. And a lot of times it's difficult to assess if they're on supplemental oxygen, but when they're ventilated, you can definitely figure it out. And that is, you can divide that into, by getting the ratio, by doing the division. If it's less than 300, it's consistent with ARDS. If it's like 300 to 200, we call it mild. 200 to 100, it's moderate. Anything less than 100 is severe ARDS. So that's one thing, hypoxia. The second thing is also thinking about what else could be an alveolar filling process, particularly water. One of the things is it cannot be mostly explained by a cardiogenic cause. So heart failure in general, we don't really think of causing ARDS. The third thing that I always think about is the acuteness of this, right? So this has to be an acute presentation of a disease process. Usually I think it's within 7 to 10 days of some sort of trigger. And then finally is bilateral infiltrates on X-ray or CT scan that are consistent with it.
Perfect. And to Jordan and Sam, so the Berlin criteria, we think about it a lot, and I think our sort of our knee-jerk reactions, we see bilateral infiltrates, we think ARDS right off the bat. But what about this particular case perhaps leads us away from ARDS?
Again, I think it was like the 3 weeks of presentation out, not a clear trigger. That being said, I think it doesn't necessarily exclude it yet, but I would say that's the strongest argument against it.
Yeah, absolutely.
Yeah, I totally agree. And it's like,
no, sorry, Sam, go ahead.
I don't know, I was gonna say is we don't have prior imaging, so I agree. Like it's acute onset within 7 days of a known insult. So I could have had pneumonia a week or so ago, and now means they already have possible, but the chronicity definitely suggests against it.
Yeah, that's really, really excellent. And you know, if for instance he did have that ARDS pattern, but he was longer than 7 days, then the clinical entity that we often invoke then is AIP, or an acute interstitial pneumonia, essentially idiopathic ARDS when we can't identify that initial insult. All right, so you guys had asked about a CT scan. Are you ready to see the CT scan?
Yeah.
One thought before we go on.
Yeah, absolutely.
Just looking at that chest X-ray, I was, you guys read it perfectly. I was impressed by the widening of his mediastinum. You know, this is a young person. It's a slightly kyphotic view, so that might be causing that. But that mediastinum is pretty prominent. It's, you know, probably 2/3 the width of the entirety of his heart. And as we're talking about, you know, things that cause alveolar filling processes beyond the 3 causes, that may just be of interest to something to keep an eye on.
Perfect. Dr. Connors, I had no idea you were on. Please feel free to chime in with any more expert advice.
No, you guys are doing great. I'm enjoying this case. It's fun.
Yeah, I agree, Danny. Dr. Connors kind of snuck up on there.
You guys are doing excellent. All right, so I think all of us are interested in seeing the CT scan. So this is going to be a video. Hopefully the video plays, but it's going to scroll down through the chest in slices. I can always replay it if you're interested. So here we go. All right. Do you guys want to see that again? Do you guys feel like you got a good enough look at it?
I mean, I want to see it probably another 100 times, but I think for now we're okay. Yeah, I think, and Jordan, I'll just kind of go ahead and just start with my initial thoughts and then you guys can add into. So, the first thing, it's right off the bat, looking, it's apex to base. It's kind of diffusely throughout the entire lungs. And you have this almost, a lot of people say ground glass opacities. Yeah, I mean, ground glass is so non-specific, but yeah, it kind of looks like a ground glass opacities. The way I also think about it is it peripherally dominant? Is it around the airways, or is it like localized to a certain section? And this actually, like, if you look at the apices and coming down, initially looks like it's really predominantly around the airways, and then eventually becomes more peripherally predominant. One of the other things to think about is looking at the airways. Are they super large compared to the blood vessels? So is there any evidence of bronchiectasis? And I would say no, there's no evidence of bronchiectasis. Other thing to think about is there any airways going into consolidations, to think about like air bronchograms? I didn't initially see any, so I don't really think there's a frank consolidation. I mean, maybe a little bit on the left base potentially. I'd have to look at it a couple more times. And then the other thing to always think about is like this pattern, this patchiness and pattern. One of the thoughts I always have is this potential crazy paving, is what it's called, and also honeycombing. There are all these different terms to describe, different types of potential interstitial lung diseases. I'll let you guys talk some more.
I agree, Shoaib. I kind of thought about crazy paving too, that septal thickening, like the thickening of the interlobular septa, and then some ground glass in some areas that maybe look consolidated, but then you also have areas of airway that are spare, that you can see normal lung parenchyma there as well. Like septal thickening with ground glass, but also with areas of normally aerated lung, I think we could crazy paving.
Sam and Shoaib, that was excellent, and I think pretty clear why you guys are both eventually going to be pulmonologists. But yeah, so that's a really, really fantastic read. So what you guys were looking at on this CT is crazy paving. And so like Sam and Shoaib both said, crazy paving, you have the ground glass opacities with interlobular septal thickening. And so over here on the right side of the screen, we have pavement essentially. And so what this is mimicking is the interlobular septa, if you think about it, are the edges between the concrete, and then the middle is going to be predominantly your alveoli. And so you've got ground glass or an alveolar filling process within the alveoli, with a process putting more fluid or more of some sort of material within the septa, so in the dividing spaces between those air sacs. And then here's another sort of more anatomical view, so you can see that polygon of the airway with the septa, the vessels. But yeah, so the ground glass opacity with that septal thickening is characteristic for something called crazy paving. So going back to the whiteboard here, how does the crazy paving change your guys' differential, amend it? How does that, what are you thinking?
The first thing I think of is PAP, which we mentioned as like a more rare cause of alveolar filling, so pulmonary alveolar proteinosis.
Perfect. Yes. Yeah, so PAP is kind of our sort of our most common alveolar thing we associate with crazy paving. Like if we got a mix-app question, we'd probably select pulmonary alveolar proteinosis right off the bat. But do you guys think about any other illnesses or diseases which can cause the same imaging pattern?
I'll be the first one to say I don't know, and I'm excited to learn.
I honestly don't have a specific differential for crazy paving other than PAP. When I think about ground glass and septal thickening, I think about fluid. That doesn't look like a classic heart failure CT. I don't think it's that like patchy pairing. But also like septal thickening, I'll think about cells, like rarely get sort of lymphangitic spread of like carcinoma. I don't know if that gives you the crazy paving in addition to the septal thickening, but I know like lymphatics and blood vessels run in your septum.
Yeah, Sam, that was excellent. And so I think actually the way you thought about that was perfect. So what you said was you're looking for things that fill. And so you were looking for cells, you were looking for fluid, and then you were looking for basically like other inflammatory processes. And you were just sort of thinking anatomically, if I put something in that space and it fills it up, will it give me the same pattern? And that's exactly correct. And so the crazy paving pattern, while we most commonly associate it with PAP, you can also see it in HP. You can also see it in a lipoid pneumonia. You can also see it in like a cryptogenic organizing pneumonia, or like BOOP, or whatever we're calling it these days. You can see it associated with the heart, so cardiogenic pulmonary edema or non-cardiogenic pulmonary edema and ARDS. And then you can also see it from infections. So mycoplasma is one that you can see found online associated with this. And then the other one that you guys mentioned earlier, is PJP. PJP can also be associated with the inflammatory changes that causes crazy paving as well. And so while we often think of PAP just broadening our differential, so we have this differential, we're sort of narrowed it now to an alveolar filling process with crazy paving. What is the next test or next series of things that you guys would like to order or like to do?
I think we should bronch him.
Yeah. Anyone have any disagreements or any hesitation about bronching this guy?
I think a decent amount of oxygen to bronch him. You might have to intubate him to bronch him.
And Sam and Shoaib, as upper level residents, let's pretend you're admitting this guy at Denver Health overnight. Is this someone that you're going to call your attending in to intubate and bronch overnight, or is this something you'd wait till the morning?
Well, that's a good question. I think, I have a high concern for him that, keep a close eye on him, but I don't think you need to urgently intubate him. Anything done urgently is never preferred over something done a little less urgently. But I think if you can get him intubated to the next day and then bronch the next day, I think that's totally appropriate. The one situation that I feel like is important to get bronched really early is if he has profuse hemoptysis and you're concerned that he's having like a capillaritis, where you actually need to get him like plex potentially. So I think that's when I start getting a little bit more concerned and want to get him bronched right away. I think in this situation, I would potentially wait till the next day, but I would talk to my fellow.
Great. And then just you guys, one more question on management here. Would you start this man on antibiotics? And if so, what would you go with?
I 100% would. And sorry, I'm taking all the thunder here, but I definitely would. And the reason why is, again, you don't have 100% of a diagnosis yet until you get that bronch in and you know exactly what cells are coming out. I would probably put him on antibiotics because, with sepsis and any other type of infection, the most important thing to decreasing mortality is getting early antibiotics. What I would give this gentleman would be all the this guy actually, he hasn't had any healthcare exposures, but he's so sick. So a couple of things that I definitely want to cover for him. I would make sure he has some gram-negative coverage. I don't think he needs pseudomonal coverage right away, given that he hasn't had any hospitalized exposures. I'll give him gram-negative coverage. I would potentially do MRSA coverage because there's a lot of MRSA out in the community, and then definitely atypical coverage as well. But I could be swayed to get pseudomonal as well. He's so sick.
Yeah, I think that's great. So this gentleman got vanc, cefepime, and he also got atypical coverage as well. And I will say that the team waited till the morning before the patient underwent a bronchoscopy. So let's go back to our stuff here. So I'll tell you guys, just in case you guys were wondering, he did get an echo because of the weight gain, and we're just going to go through this for time. But essentially what the echo showed was the D sign. So he had actually RV failure with volume overload on the right side, which explained his weight gain. And then this is his apical 4-chamber view, and you can see that his RV is quite large on that left side of the screen, and his LV is smaller. Okay, so he gets his bronchoscopy, and this is the fluid that comes back after a 60 cc aliquot of BAL. And so for our discussants, does this fluid return make you think of anything that you guys talked about in your differential, point you in any one direction?
It looks pinker and cloudier than normal. I think protein would look like that. I mean, I guess a pretty cellular material could look like that. I don't think it looks overtly purulent, but it's a little hard to tell. It's like more white and cloudy at the bottom.
Yeah, I mean, I agree. I mean, the one thing to always think about is this blood. It does not look like diffuse alveolar hemorrhage. It's not a lot of blood. I would say the one time I have seen somebody with alveolar proteinosis, and they did a whole lung lavage. It did look like this. That's what I'm concerned about.
Great. So let's put our nickel down here. Sam, Shoaib, and Jordan, what is your final diagnosis for this patient? Because the diagnosis will be revealed after a pathologist walks into the room.
I'll also go PAP. I think it looks like that.
I think, given I don't know a lot about PAP, I think I've only read it once in med school or something, but given that it doesn't fit my illness scripts for any of the other kinds of bilateral alveolar filling processes that I am aware of, I will kind of also go with the PAP because it's not fitting my other illness scripts.
Yeah, I agree. Sorry, go ahead, Danny.
Oh, I was going to say, Jordan, that's a phenomenal way to think about it. Right? You create your illness scripts, you work things into your illness script, but when the illness script doesn't work, what's left over? And so I just think that's phenomenal diagnostic reasoning. Go ahead, Shoaib.
Yeah, what I was going to say is like a lot of things do fit with PAP. The one thing that I would be curious, because I actually don't know much about this, is what is the incidence of right heart failure with PAP? I think that is one thing that I would be kind of curious to learn about, just because that's a pretty pronounced right heart there for PAP in the subacute course. But it does look like PAP. The crazy breathing fits it, the kind of subacute nature, and as well as this bronch. So I'm going to stick with PAP.
Great. So we got 3 votes for PAP. So studies return. So a pathologist walks in and says that the fluid is milky white and opaque and contains PAS positive or periodic acid shift positive macrophages. And then a lab returns, and the gentleman is positive for the anti-GM CSF autoantibody. So in conclusion, he had acute hypoxemic respiratory failure and RV failure due to autoimmune pulmonary alveolar proteinosis. So you guys were absolutely 100% correct. This gentleman did have PAP, and he was diagnosed with it in this hospital stay. So you guys mentioned this, the therapeutic whole lung lavage. So Dr. Sipple, one of our expert clinicians here, who is actually a PAP, an international expert, he performed a therapeutic whole lung lavage on this gentleman while he was in the hospital, a couple actually. This is his initial lavage specimen over here, so it's cloudy and somewhat pink. And then as he lavaged 15 to 17 liters, it gets progressively more clear as that proteinaceous material is cleared out of his lungs. So this gentleman, since that diagnosis, has underwent 3 whole lung lavages and been receiving an inhaled anti-GM CSF antibody. This is his chest x-ray a few months ago when he came in for follow-up. So not completely better yet, but significantly improved. So really, really quickly, because I know some people have to run to clinic. So PAP, there's 2 big ways to think about it. There's the autoimmune form of PAP, and then there's secondary. And secondary is typically associated with hematologic malignancies. And autoimmune is the one that's found in most of our adults. It's about 50 to 80% of adults. And so you diagnose autoimmune PAP by getting the GM-CSF antibody. And that antibody is actually 100% sensitive and 100% specific for autoimmune PAP. And so if you get that antibody and you have the characteristic imaging findings, your workup is essentially done. So how do you treat these people? You treat them with therapeutic whole lung lavage, so WLL, and then you can give them plus minus a medicine called sargramostin, which is an inhaled GM-CSF antibody, basically inhaled GM-CSF. And so what it does is it helps clear out the faulty GM-CSF, the faulty macrophages, and the faulty surfactant from the alveoli, and helps them oxygenate better. And so for these things, you have to treat them with whole lung lavage periodically if they're still symptomatic. The sargramostin is more of an experimental treatment and is continued for basically an unknown duration of time. But most importantly, for these people who get PAP, you want to tell them to stop smoking, and you want to tell them basically to live as healthy a lifestyle as possible. And so if you stop smoking, the rate at which you get whole lung lavages actually decreases. And so one of the interesting things about PAP is about 50 to 80% of people smoke who get the autoimmune form. And so really hammering that home is critical. All right.
Hey, Danny, one question. Have they looked at using like rituximab for treating these folks?
Yeah, Levi, great question. So rituximab is either a second or third line therapy. And so if you are failing whole lung lavage or failing the sargramostin or can't tolerate it, then rituximab is listed as one of those alternative possibilities.
Cool, thank you.
All right, to our discussants, that was fantastic. You guys did an absolutely wonderful job of discussing that case with some really, really good learning points. I'm incredibly impressed. Dr. Connors, thank you for helping out as well.
I'm impressed as well.
Any takeaways from this case? Anything you guys will change going forward, or things you'll teach to your team?
I think the one thing that I would potentially highlight is, again, thinking about that, your broad differentials, and also thinking about the alveolar filling process, because as you mentioned, there's the common three, but then there's also a bunch more, and protein is rare. Like, this is not a common diagnosis, but if you think about it broadly, then that's something you can definitely get. And also, like, for us who are there in the middle of the night, you know, I think it's important for us as residents overnight to stabilize, take care of patients, think about everything, particularly the things that can potentially kill patients, and then realize that you have backup in the morning. So that's kind of my takeaway a lot of times.
For me, it was interesting. Like, I really hadn't heard of PAP ever, but it's nice thinking about the physiology and that everything from the history, exam, laboratory findings really matches up with what we ended up finding in the lungs. So just building that clinical picture and thinking about the physiology was really interesting for me.
Yeah, and on top of that, I think it's good to revisit leukemoid reaction too. That's like a very striking white count, and it was a good reminder for me about differential there. Also, just a clarifying question, Dave. So presumably this guy's had PAP for a while and essentially got core pulmonale, so is that right, heart failure, just chronic hypoxemia?
Yeah, that was the way we tied it together, was we think that he probably actually had symptoms for longer than 3 to 4 weeks. And this has sort of been slowly progressive. And then something tipped him over. But yeah, core pulmonale from progressive PAP.
Okay.
Thank you.
Thanks, Danny. That was an awesome facilitation. Appreciate it.
Yeah, thanks, guys. Once again, I really appreciate it. To all the discussants, thanks so much. If anyone is interested in doing this in a future conference, like I said, let Corey and I know. And otherwise, have a great rest of the week.